Once again, welcome everybody. We're going to get started here in just a second. So again, welcome to the webinar, everybody. We're going to get started in just a minute here. All right, looks like we got quite a few people in here, so let's get this started. Welcome to the Sonosite Behind the Scan webinar, Regional Block Perfection from Fundamentals to Advanced Skills, with our guest speaker, Bradley Quarles, CRNA from Salem Anesthesia. My name is Chris Pennell, and I'll be hosting today's webinar. Before we begin, please be advised all attendees are muted, and we will be conducting a Q&A session at the end of the presentation. And while the presentation is going, feel free to send those questions in, and we'll be sure to get to them at the end of the Q&A session. If you're on the Zoom stream, you can type your questions into the Q&A box and the toolbar located at the bottom or the side of your screen. And for our viewers on YouTube and LinkedIn, you can enter your questions in the chat box, and I'll get those when we get to the Q&A section as well. This webinar will be recorded and archived for future reference on our webinars page and on the Sonosite Institute. And there's a QR code on the slide right there where you can scan to visit our webinars page. To get started, let me introduce Bradley Quarles. Bradley is a graduate from the University of South Carolina School of Medicine and works for Salem Anesthesia in Greensboro, North Carolina. For more than 30 years, Salem Anesthesia has provided uninterrupted anesthesia services as a CRNA-owned practice, the longest of its kind in North Carolina. Bradley is a leader within Salem Anesthesia, providing a plethora of ultrasound-guided peripheral nerve blocks daily, formulating and implementing a multimodal anesthesia protocol, reducing patients' narcotic use postoperatively, and much more. Bradley was awarded the Order of the Silver Crescent by Governor Harry McMaster, which is the highest civilian honor in the state of South Carolina for his work with suicide prevention. With that, I'll get our presentation started in just one moment here.
In North Carolina. And I'm so thankful for this opportunity. I want to start this webinar by thanking all the wonderful people at Sonosite for reaching out to me to teach this webinar and all the anesthesia professionals who played a role in the anesthetist I am today. Throughout this presentation, we will discuss some foundational and global concepts, but we will also touch on advanced topics and some case studies as well. So let's begin that by discussing the global benefits of regional anesthesia. The bullet points provided here are a synopsis derived from a research article produced in 2024 titled The Influence of Regional Anesthesia on the Systemic Stress Response. And I would refer people to look at that article for more in-depth as it relates to overall information. But overall, regional anesthesia inhibits the neuroendocrine response by reducing the release of cortisol and catecholamines, which maintains hemodynamic stability and reduces myocardial oxygen demand. Regional anesthesia also inhibits the sympathetic nervous system, leading to improved cardiovascular outcomes. It should also be noted that regional anesthesia mitigates the inflammatory response by reducing pro-inflammatory cytokine levels, reducing the risk of systemic inflammatory response syndrome, sepsis, and pulmonary complications. Regional anesthesia also reduces postoperative pain, opioid consumption, and the incidence of cardio and pulmonary complications, especially in the elderly and high-risk patients. It's largely that I believe that regional anesthesia is the future of healthcare when it's deemed safe, and it's not contraindicated based upon the patient's morbidities on the medications that they're taking and if they withheld certain medications such as blood thinners, etc. And as a result of performing at regional anesthesia, we're really able to care for a larger sector of patients who are more critical because we do not have to run them on such a deep anesthetic depth that it would suppress their sympathetic nervous system. So it helps out as it relates to more access to care to patients, and especially elderly, obese patients or cardiopulmonary patients who are the most optimized. So as healthcare in America continues on in that our patients are becoming sicker and sicker. Regional anesthesia really has more of an important role in providing care to people. And ultimately, regional anesthesia, with all the benefits that I've discussed, it really helps those reach their activities of daily living in a more efficient manner. And these are some of the overall benefits. And I love performing regional anesthesia, and I can't wait to continue to discuss some more of the benefits and get into it throughout this presentation. Now that we have obtained a global 30,000-foot view about regional anesthesia, let us begin to narrow our focus to the ultrasound machine and discuss some key terms that are important to know. While these aren't all the terms that are important, I would like to refer viewers to a research article titled Ultrasound, Basic Understanding and Learning the Language. Throughout this presentation, you'll come to find that half the battle with regional anesthesia is just understanding the terminology and the anatomical terminology along with the landmarks. So if you really understand this, everything else can kind of build. These are the very foundational concepts. So let's start off with echogenicity. It refers to the ability to reflect or transmit ultrasound waves in the context of the surrounding tissues. Whenever there is an interface of structures with different echogenicities, a visible difference can be seen and compared and contrast on the screen. So based on the echogenicity, a structure can be categorized as hyperechoic, which means white on the screen, hypoechoic, which means gray on the screen, and anechoic, which means black on the screen. Bone, for an example, appears as black or anechoic on the ultrasound with a bright hyperechoic rim. Because the ultrasound beam cannot penetrate bone, it casts an acoustic shadow beyond it. Cartilage, for an example, appears as hypoechoic and is more penetrable by the ultrasound machine than bone. Blood vessels appear as black or anechoic. Veins are usually easily collapsible, and they also appear as black or anechoic. Arteries, though, they are pulsatile, obviously, and they're not as collapsible, and they do not collapse at all with moderate pressure applied by the transducer. There's a great feature that on the anesthesia, excuse me, on the ultrasound machine, that's the color Doppler. And there's this acronym called BART, which means blue away, red toward. And when we utilize the color Doppler, you'll see that pulsatile flow of the artery. It can serve as a landmark. But when you see the blue going away, red toward, that's an acronym that you can utilize as it relates to vein arteries and other landmarks. Some other key terminology to know is in plane versus out of plane. The in-plane approach directs the needle parallel to the probe's long axis, providing a continuous view of the entire needle from the tip to the entry point. The out-of-plane method inserts the needle perpendicular to the probe, showing the needle tip as a bright dot against the long axis of the structure. In plane is used when you're trying to see the entire needle, which is obviously very important for all our regional blocks, especially the upper extremity blocks such as the supraclavicular, interscalene, and those will be featured later on here. But the out of plane can be used in situations where you need a different approach or when space is more restricted, like inserting a catheter or performing a biopsy in a tight area. Two other important terms that I want to talk about are artifact, which is an error in the image. And really, that just comes with diagnosing what is going on. Do you need more gel? Is it your contact with the transducer to the patient's skin? Um, so that's one thing, but also gain and depth. Gain will adjust the overall brightness of the image on the ultrasound machine by amplifying the return signals, while depth more so discusses the depth of which your ultrasound is looking into the patient's body habitus and is looking into the body. So if everything that you're looking at is very superficial on the surface, you don't need a lot of depth. But if something is, if you can't examine exactly all that you need to examine nerve-wise, you can increase the depth to see that. And we'll also go into talking about utilizing linear probes versus curved linear to examine that depth. So some fast facts about the ultrasound machine. So ultrasound is a technique by which images are created utilizing high frequency sound waves, as we see on this image featured below here. And they're produced by the transducer. So you put the transducer on a patient's body and it emits sound waves at your target that you want to view. And it reverberates back to the transducer, and that's how you see an image. The ultrasound transducer produces the sound waves, and they can either be considered high frequency or mid frequency or low frequency. High frequency probes are preferred for ultrasound images that are very superficial, meaning very close to the skin, like 2 to 4 centimeters, while mid range frequency probes are for slightly deeper structures that are considered like 5 to 6 centimeters. However, when the ultrasound imaging of deep structures, such as somebody who has a large body habitus, or you may have larger tissue to traverse to view something, such as maybe you're doing an IPAC block or you're doing a popliteal sciatic block on somebody who has a larger leg, you may need a low frequency probe. And this allows you to view deeper into the patient's body with the ultrasound machine, utilizing the transducer. So really, when you're determining the correct choice between the probes, it's really all based upon the frequency and the view that's presented, whether it be linear or curvilinear or any of the other transducer types that you can utilize based upon the required depth that is necessary to perform your task. Anatomical positioning. So this is really important, and this is where we're starting to begin to talk about building upon foundational concepts. If you understand the key terminology, as I mentioned prior, as well as these anatomical terms, you can really build upon your regional anesthesia skills and knowledge. So as you see in these images, not only on the left, we talk about things being distal, proximal, medial, lateral, superior, inferior, cephalac, caudad. Knowing those terms, not only in relation to the patient, but also in relation to the patient and the transducer and on the ultrasound. Um, those are really key. You have to know what you're talking about as it relates to the ebb and flow of the ultrasound machine, and really providing and performing regional anesthesia as an art form. And how I view it is the transducer is kind of your brush, and you're painting this picture when you perform regional anesthesia based upon how the local anesthesia spreads or how the pictures present on the ultrasound machine. But the first key thing is you have to know how to discuss anatomical positioning. The other thing is the proper positioning. I'll go on to discuss further on throughout this presentation about the importance of positioning, but I really relay utilizing different transducers based upon securing an airway. And the first thing I want to start off by saying here is imagine us as anesthetists. If you're going to secure an airway, one of the key things is proper patient positioning, getting them in the sniffing position, ensuring that they can ventilate appropriately, etc. Take that same mindset and that same intent and apply that to your regional anesthesia blocks. Having proper patient positioning is paramount to all things that you do for regional anesthesia, because there's a dance that you have to do with the you and trying to visualize things on the ultrasound machine, but also with the patient. Make your life easier by positioning them optimally so that you're not fighting them in the sense, if you will, with their poor positioning, and you can't view everything you want to. A lot of the issues can be resolved with better positioning or optimizing it. So obviously we see the prone, supine, lateral recumbent, both right and left, Fowler's and Trendelenburg. Um, Mainly, predominantly, we use the lateral recumbent position for our lower extremity blocks, and kind of more of a semi-Fowler's for our interscalene and supraclavicular blocks. Um, a lot of that's for airway patency, while we don't utilize any kind of prone positioning. Always make sure that the patient can ventilate. But I'll discuss further about how important patient positioning is, and I will parallel it very commonly to securing an airway when we're going off to sleep with the patient, intubating wise. So now, building upon that, let's talk about optimizing patient positioning and how important it is. Positioning is paramount. First bullet point, and I think if you don't learn anything else from this slide, I think positioning is paramount. Just be intentional. Take your time. Um, and the first key to success is setting yourself up for it. And here we go. So position the patient for a nerve block with the same intent as you would if you were going to prepare to intubate a patient. Take the necessary time to have the patient positioned just as you need them to optimize your needle placement and to facilitate the execution of the nerve block. You shouldn't rush your positioning when securing an airway, so don't rush your positioning when you're trying to perform a regional anesthesia block. Patient positioning becomes even more important as the patient's body habitus increases, because you're going to use different kind of a transducer. Maybe you're using a curvilinear, things become much more distorted if they've had a prior surgery in the area. So make your life simple and make it as standardized as possible. When positioning the patient, always consider the patient's ventilatory status, such as if you're using sedative medication, whether you're using Versed, fentanyl, Precedex, ketamine, whatever you may use, always consider their airway in the process. So now we're going to talk about executing an excellent nerve block despite body habitus challenges. There's always going to be challenges as it relates to securing your airway on an obese patient, or performing a nerve block on an obese patient, or even getting obtaining an IV in an obese patient. And the way I always say is that everybody looks good when everything is going really well, but how do you mitigate, and how well do you do when challenges pose themselves, such as dealing with larger body habitus that you have to traverse either through needle wise or utilize different transducer types. So let's talk about that, and let's talk about how we can mitigate some of that and make our lives a little bit easier. So again, the first bullet point, positioning is paramount. Um, so to expand upon that, let's talk about I'm gonna paint you a picture. I think that's probably the best way for me to do this. So you're preparing for your next nerve block and you're interviewing the patient and you examine their kilograms. And for me, the first thing I think about is, okay, what kind of block are we doing? Is it upper extremity or is it lower extremity? Okay, once I have that, typically if it's upper extremity, I'm always using a linear probe because the majority of everything is very superficial. But if we're doing a lower extremity block, am I going to use a linear probe or am I going to use a curved linear probe? In relating everything back to securing a patient's airway, the way I view it is, think of the linear probe as your macromolar blade and view the curved linear probe as a glide scope as it relates to performing blocks on the lower extremity. For simplicity purposes, let's do a comparison of contrasting of a linear and curved linear probe. For us, with the Sonosite ST, the machine that we love, and you'll see a video about this later on, we have a curved linear probe and we also have a linear probe. So the linear probe is flat and rectangular in terms of its probe face, while a curved linear probe is curved. The frequency of a linear probe is very high, which is good for superficial structures, things that are very close to the skin surface. Curved linear is a low frequency to mid frequency, which allows us to see deeper through the patient's skin and to the target that we need to see. The image shape for a linear probe is a rectangular field of view, while the curved linear probe has more of a sector or like a pie shape. And really practice use the curved linear probe on individuals, just because you have to train your eye to the differences in the imaging shape. As relates to the penetration, you'll have poor penetration with a linear probe, but high resolution at the surface. With a curvilinear, you'll have good penetration for deeper structures, as I mentioned. So when would a linear probe be good for? Patients who are um, smaller in kilograms, not that many kilograms, they're smaller patient size, upper extremity blocks, superficial structures, while a curvilinear is better for deeper structures, abdominal type blocks or imaging, OB or deep musculoskeletal imaging. So this is where we begin to expand upon the foundational concepts and start getting into more of the higher level. And this, with the nerve anatomy in this image, it's really essential to understand this, and we'll build upon it a little bit further as I talk about understanding objective versus subjective signs that our block will work. And again, this is just an art form with anesthesia, and this is regional anesthesia, and this is really the fun part in my mind. So understanding nerve anatomy is really important and necessary for anyone who wants to perform regional anesthesia on a consistent basis. Understanding nerve anatomy also keeps the patient safe as you're a more knowledgeable provider. In this image, we're examining the nerve from a broad view as it transitions from the epineurium to the perineurium to the endoneurium. We gain a more in-depth view of what makes a peripheral nerve. To speak very broadly, peripheral nerves are part of the nervous system that connect the central nervous system, our brain and spinal cord, to the rest of our body. They carry sensory, motor, and autonomic signals between the central nervous system, organ, skin, and muscle. So let's talk about the structures. So nerve fibers are bundles of myelinated or unmyelinated axons that transmit an electrical impulse. Myelinated fibers transfer an electrical signal faster than those that are unmyelinated. The myelin sheath will act as an insulator, and the electrical signal jumps between the gaps in the sheath called the node of Ranvier. This is a process called saltatory conduction. Unmyelinated axons conduct signals continuously along the length of the axon, which is significantly slower. The epineurium is the outer layer of connective tissue that encloses the entire nerve. It encloses all the fascicles, which are the nerve bundles, and they contain blood vessels that supply the nerve. It also acts as a cushion against external forces. A nerve fascicle is a bundle of nerve fibers or axons within a nerve, particularly in the peripheral nervous system, that are held together by a layer of connective tissue called the perineurium. Multiple fascicles, along with other structures, form a main nerve trunk and are surrounded by other sheath known as the epineurium. Fascicles are the fundamental structural units of a nerve trunk. A single main nerve can have many fascicles. So now let's talk about the endoneurium. The endoneurium is a connective tissue surrounding individual nerve fibers. The endoneurium supports the individual nerve fibers and contains the blood vessels that supply them. It helps maintain the internal environment for the axons and the Schwann cells. And lastly, the perineurium. These are connective tissue surrounding bundles of nerve fibers called fascicles. So there are three types of nerves. We have sensory, motor, and mixed. So let's talk about sensory. Sensory nerves carry sensory information from the body to the central nervous system. Motor carry motor commands from the central nervous system to muscles. And mixed are just as they sound. They contain both sensory and motor fibers. Understanding this image and how all this works really helps the practitioner develop the why behind why a block may work or may not, and really beginning to understand that art form of what the patient presents as and how the block is beginning to take effect, such as they're starting to feel their arm feel a little tingly, or there's harder to lift up, or whatever pain they had is starting to subside. And really also, once you perform regional anesthesia on a consistent basis, you'll begin to almost develop a tangible sensation as you traverse through patient's tissues, but also get into different things such as a Vloca sheath that we'll talk about in the popliteal sciatic block section. So just understanding that anatomy is just paramount to be a safe practitioner, but also to understand the why behind everything as it relates to nerve conduction and regional anesthesia. So now we'll discuss objective versus subjective signs of block success. So when I first started performing regional anesthesia, I really was trying to understand, well, how do I know a block's going to work? The obvious sign is that you're performing a lower extremity block, like a popliteal sciatic block, and after performing the block, the patient has really the inability to dorsiflex and plantar flex the foot. And once they lost that motor control, I knew that in the foot, that is, I knew that, well, the block should be successful. That's an objective sign that I can see that when comparing, let's just say, for example, the right foot, which is the operative foot that I blocked, to the left is much stronger and is as it was prior, the right foot was prior. But now that the right foot, the operative foot, is showing that it doesn't have that motor control and they feel hard, it's heavy for them to move it. Those are objective signs. But um, building upon the last slide, let's talk more about the why in the nerve fibers. So anesthesia and performing ultrasound-guided peripheral nerve block is an art form, like I discussed. There is a delicate dance which is conducted between the anesthesia professional and the patient. Whenever I'm performing a nerve block, I look for subjective as well as objective signs that the peripheral nerve block will work in the operating room. This slide is extremely important to understand for those who perform nerve blocks on a consistent basis because it further reinforces your understanding of the why behind the changes we see when we're performing a block and after the block is finished. In this image, we see local anesthesia, which are the blue dots surrounding a nerve. Within each nerve, you have an array of nerve fibers, B fibers, C fibers, A delta, gamma, beta, alpha, and vascular core, as you see on this image over here to the left. The outermost fibers are our B fibers, which controls our autonomic functions, and these are the first to be blocked, while our motor function within the A alpha are the last to be blocked by the local anesthesia. Therefore, when one is performing a block and the patient states, my arm or my leg is starting to feel tingly, warm, or heavy, or the pain, like I said, is starting to go away, then we know based upon this anatomy that you see of the nerve, where the local anesthesia is starting to bathe and how it's starting to progress throughout it. So let's talk a little bit more about the nerve fibers. So A delta fibers are thinly myelinated, like we discussed last time, fast onset because of the myelination, and they transmit information primarily related to acute pain and facilitate a withdrawal reflex upon the synapse in the dorsal horn of the spinal cord. C fibers are smaller and they're unmyelinated that require a higher threshold of stimulus than the A delta fibers. These are responsible for the slower onset and deeper dull pain after initial insult. And let's talk about now decreasing diameter and the velocity. So you have proprioceptors, you have mechanoreceptors, and you have nociceptors and thermoreceptors. So proprioceptors are the A alpha and A beta. The mechanoreceptors are A beta and A delta, excuse me. And the nocioceptors and thermoreceptors are A delta and the C fibers. When you look at this image here, you'll see that the thickest nerve fiber is the A fibers. The thicker a nerve fiber is, the harder it's going to be for you to get local anesthesia around there. And that's going to take a longer time for that to have onset. So as I mentioned, painting another picture for you, if you're performing a nerve block and the patient says, oh, my arm's starting to feel a little warm, well, okay, or tingly, then we know which nerves we're starting to kind of bathe in this one. And then as they start to say, well, it's hard for me to start lifting my arm. Well, then based upon this picture that is provided, if they start to lose that motor control, then you've densely started to have that nerve block surround all these other kind of nerve bases, and your block should be successful in the operating room. So some of the subjective is what the patient tells you, like it feels heavy, it feels tingly, I can start to feel it on my fingers. Okay, that's subjective. Now we know we're starting to work a little bit, starting to have the onset. But when we start observing the objective of motor loss of control, or you start to see that their extremity starts to become a little more vascular looking, like you can see their veins more, or their extremity feels warm due to regional anesthesia providing a vasodilatory type process, then we know that that's objective. We can see that this is starting to really work and it's going to be just fine for the patient. Um, so yeah, understanding this slide is paramount, and it really helps you understand the progression of how the nerve block is flowing throughout them. And every patient's different. There's sometimes that you'll do a nerve block and quickly they'll have a motor response, or they'll lose that motor control with the same milliamps on the nerve stimulant, the same target of everything, but it's just all based upon their anatomy, their perfusion, etc. And that's some of the challenges, but also the fun in regional anesthesia is that it's always different. The next few slides are ultrasound images of blocks that I personally have conducted on patients at our center. This is a popliteal block, which is evident by the common peroneal nerve, which can be seen on the left, and the tibial nerve on the right. They are seen by their honeycomb hyperechoic-like image. Below the tibial nerve is the popliteal artery. This block is indicated for foot and ankle procedures. Our podiatrist and orthopedic surgeon will commonly request this block at our facility. The patient position for this block is the lateral recumbent position. Once the patient is positioned in the lateral recumbent position, we place a pillow in between their legs, and the first thing I do is place the transducer behind the popliteal fossa crease in a longitudinal orientation with the transducer. I will first identify the popliteal artery, and after I identify this, the tibial nerve should be superior to the popliteal artery. I will then move the transducer cephalad to watch for the common peroneal nerve to begin to meet the tibial nerve. The part where the two nerves are almost touching is where I will block the two nerves by utilizing a nerve stimulator between zero point 0.3 to zero point 0.5 milliamps. I will commonly use a linear transducer for this block unless the patient has a larger or more muscular leg. Um, the image to the right, it shows the ultrasound needle and the spread of local anesthesia around the tibial nerve. We call this local spread the donut sign, as it spreads in a circumferential manner around the nerve. This portion of the block is a motor block. Commonly for us, we'll utilize a 22 gauge 4-inch needle, short bevel needle that is, for this portion. And we administer a total of 20 milliliters of 0.5% bupivacaine with a 1 to 400,000 epinephrine as a cardiac marker to ensure, we're safe for the patient. Once you perform a lot of these blocks, you'll begin to become really one with the ultrasound machine and the short bevel as you traverse through the skin and through all the tissues. And the one thing I wanted to mention how it's like an art form is there's this thing called the Volcus sheath, and it surrounds the tibial and the common peroneal nerve. And once you penetrate this sheath with your ultrasound needle, you almost feel a release. And when I'm in this space, this is where I ask for the nerve stimulator to be turned on, and I have to go all the way up to zero point 0.5 milliamps just to see for that motor response. And the motor response and the nerve stimulator is really important to all the motor blocks that we do because this is another objective sign that I see what I think I see, and this nerve stimulator is confirming all of this. It's almost like a double, a safety check for the patient, but also to prove to me as well that we are correct, we are where we're supposed to be. And to further expand upon that, if you have a patient that's of larger body habitus, and despite optimal patient positioning and all attempts to facilitate the block, the nerve stimulator can be your best friend. And when you get near the nerve, it will elicit a motor response. And that will help you identify the correct area where to inject local anesthesia. So that's just another tidbit there to kind of help you out. So just another that's us there. That's that there. And a further note about Volcus sheath is that it's the connective tissue that encloses the sciatic nerve that is, and surrounds the main divisions between the tibial nerve and the common peroneal in the popliteal fossa. So now, as I mentioned, I'll discuss a case study for this to get some more mileage out of it. So the case study is this patient here in particular arrived to the facility for a total ankle replacement by one of our podiatrists. It was actually the first one done at the facility, which was very exciting, and I really wanted to be a part of the case. We performed this popliteal sciatic block along with a saphenous nerve block for this patient, and we used Exparel based upon how involved the procedure is. And Exparel is approved for adductor canal and sciatic nerve blocks. The patient received a general anesthetic after they had the nerve block in pre-op with an LMA. They were provided 30 micrograms of Precedex. 2 milligrams of Versed was provided to them in the preoperative area for the block, and I gave them the 30 mics of Precedex throughout the time period of them being in the operating room. They got 15 milligrams of Toradol, 100 micrograms of fentanyl, 8 milligrams of Decadron, and 4 milligrams of Zofran. And this is just kind of discussing some of the multimodal approach of what we do. The patient was called 2 days postoperative, 5 days, and 10 days postoperatively. And actually, I called them personally. Where we work, we collect a lot of data as it relates to our nerve blocks, just to keep us honest as to say that we know that we're doing a good job, but also we want to see and hear from the patient as to how did we do. So it's a constant review. So we call every nerve block patient and to ask them how are they doing. Us from my anesthesia personnel, we call them. So that way, if we're having some patients that are more in pain, well, we'll review the ultrasound images to see how could we have done better. Actually, with this patient, with utilizing the Exparel in the block that was provided to them, believe it or not, this lady never took a narcotic. And that's exactly why I called her 2 days postoperatively, 5 days and 10 days. And by the fifth and 10th day, I told the patient, I said, you don't have to be nice. You can be honest and tell me if you're in pain or not. It's been 10 days post a total ankle, and I was looking over the drape and seeing how involved it was. They said, no, my pain was at a 2 at maximum, and ibuprofen took care of my pain. So this patient received a total ankle procedure at our facility, the first one, and never took a narcotic. Only received 100 mics of fentanyl throughout the whole process, so limited narcotic, but we gave a good block, we used Exparel, and we touched other receptors as it relates to their pain, and they never took a narcotic, and that's something I'm really proud of. I actually talked to the podiatrist last week as to how the patient's doing because it's been several months out. They're doing great with physical therapy. So These are some of the things. That's a full anesthetic, and even caring about them, even post-operatively, to have a call with them. This is what I really enjoy about the job and performing regional anesthesia, that they can have an involved procedure but never take a narcotic post-operatively. So that's really enjoyable. This next block is a fun one. This is an ultrasound image of an IPAC block, which stands for interspace between the popliteal artery and the capsule of the knee. We perform this block along with genicular, lateral femoral cutaneous, saphenous nerve, and nerve to the vastus medialis for our orthopedic surgeon for knee arthroplasty and cruciate ligament repairs. The patient positioning is for this block is the lateral recumbent position, similar to the popliteal sciatic. The benefit of this of the knee blocks that we provide is that they're all motor sparing. We don't provide spinal anesthetics at our facility, so it really helps the patient maintain their quadricep strength for early physical therapy postoperatively. For these blocks, as it relates to the IPAC, I'll utilize the curvilinear probe because it helps me look for anatomical structures such as the femur of the epicondyles, the popliteal artery. It gives a more in-depth view, and that's why I use a curvilinear for this one. Some patients, if they're really thin, I can use a linear, but I'll lean towards a curvilinear transducer. So I'll place the curvilinear transducer in a longitudinal orientation behind the patient's popliteal crease, just as I did with the popliteal sciatic block. I'll slide the transducer cephalad ever so slightly to find the point where the posterior surface of the femur begins to show and form a solid hyperechoic line. I will place the needle inferior to the popliteal artery but superior to the posterior surface of the femur, and will provide 20 milliliters of quarter percent, 0.25% bupivacaine in this location. When I have the needle in the optimal location, which is superior to the posterior surface of the femur and inferior to the popliteal artery, I will advance it past the popliteal artery, and I'll have our wonderful pre-op nurses aspirate to ensure that we're not any kind of vasculature, but give 5 milliliters at a time. And then I'll move the needle back a little bit, and then I'll have them aspirate and repeat this process and administer another 5 cc's of the quarter percent bupivacaine, all the way up to 20 cc's. It's very interesting when you look at images as to how innervated the knee is, because our overall goal is to anesthetize the small articular sensory nerves from the popliteal plexus and the obturator nerves, which will result in anesthesia of the posterior capsule of the knee, and it's very innervated. Um, this is the IPAC block is one that you really cannot skip if you're trying to provide a good service to a patient receiving larger knee surgery. And I want to talk about a case study for this. One is actually kind of a funny story. So the patient um, was actually around kind of my age, so it led to a very good experience preoperatively, kind of building a relationship with the patient. So the patient skated, and they skied a lot and during the summer and the winter months, which ended up leading to their knee injury. They were a really nice patient, and so the first time I met the patient, took care of them, and I wore this tie-dye cap and performed the knee block, had a really good experience, called them, doing really well. And the next time, lo and behold, they come back for the next knee, but I didn't know they were going to have their next knee. And I see him in the pre-op bay, and he said, "Man, what happened?" I'm like, What are you talking about?" And he was like, "Where's your tie-dye cap?" So I go back to the locker room. I put on my tie-dye cap to give him another knee block, and this is actually of the second knee block that I provided. But these are some of the relationships that I enjoy in the preoperative setting that I think helps calm patients down with the nerve block experience, and just performing that rapport with your patients. And that's all something I really enjoy preoperatively, not just the postoperative outcomes, but developing that relationship with patients preoperatively. So um, we provided the IPAC along with the plethora of other blocks that I discussed moments ago for the knee procedure. He was having a cruciate ligament repair, did really well. But I tell you, we don't do any spinal anesthetics at our facility. Our orthopedic surgeon um, doesn't ask for them due to all the blocks that we provide that are motor sparing. But what's interesting is I've worked at facilities where we provide a spinal along with all these blocks, but without the spinal, I can honestly say there is no sympathetic stimulation um, when you make surgical incision once you perform all these blocks. Um, this patient was 28 years old. I provided 40 mics of Precedex to this patient throughout the time period of the procedure, just because I wanted to ward away any kind of emergent delirium issues. Gave him 100 mics of fentanyl, 2 milligrams of Versed preoperatively, 8 milligrams of Decadron, and 4 milligrams of Zofran. They received an LMA with general anesthetic and sevoflurane. They did fantastic both times. Both times called them postoperatively, pain score out of 3. Um, but the IPAC is really the essential block to ensure patient comfort intraoperatively and postoperatively. This is the same patient from the prior slide, but I wanted to include this in here because these are some of the additional blocks that we provide for our orthopedic surgeon as it relates to these larger knee procedures. And so what we're looking at here is an ultrasound image of the patient's sartorius muscle, which forms a roof over the patient's femoral artery, which can be seen in the middle of the image. The hyperechoic nerve, which is immediately lateral to the femoral artery, is the saphenous nerve. Usually I'll provide 10 milliliters of 0.25% bupivacaine at the saphenous nerve. And when you approach the saphenous nerve, you'll almost feel this release. Again, this is that art form and really beginning to have a tangible experience with performing the regional anesthesia. And that's the vastoadductor membrane that you're penetrating there, that you'll feel like this release. Um, and that's that there. The hyperchoic nerve that is lateral to the saphenous nerve is the nerve to the vastus medialis. With this one, I will utilize the nerve stimulator and place the electrode on the patient's thigh, and I'll ask our wonderful pre-op nurses um, to turn the nerve stimulator to 0.5 milliamps, and we'll examine for a twitch on the patient's thigh. And once I see that twitch, I'll inject another 10 milliliters of the 0.25% bupivacaine here for further coverage of the patient's knee and the surrounding medial and anterior portions of the operative area. This is an ultrasound image of an interscalene block. The patient position for this is a semi-sitting, like semi-Fowler's position, with the head rotated to the opposite side of the operative extremity. These are some of my favorite blocks to perform due to the complexity of them, but also the images that can come from a well-done block as well. The block is performed for shoulder arthroscopies and total shoulders, which we perform at our center. The goal here is to spread local anesthesia around the superior and middle trunks of the brachial plexus in the interscalene space between the anterior and middle scalene muscles. For this block, I'll use a 22 gauge 2-inch needle and we'll give 15 milliliters. But honestly, it really depends upon the patient's kilograms. I kind of stop at 20 milliliters at maximum if they're larger kilograms and if they can handle that. But commonly, I'll remain at 15 milliliters. I utilize a nerve stimulator on all of our motor blocks, as I mentioned prior. Like I said, this is another objective way that I can assure patient safety, especially in this area where you're dealing with a lot of the vital structures here, as well as the phrenic nerve, etc. You really want to make sure you can visualize your whole needle here. I'll use a linear transducer for this block, and we begin by placing the transducer in a transverse orientation over the patient's neck 2 to 3 centimeters superior to the clavicle and over the external jugular vein. This is an in-plane block, and as you advance your needle, I will examine for the nerve stimulation of the patient's arm. I'll ask the pre-op nurse to aspirate, and once we've obtained optimal placement, we'll inject 5 milliliters of 0.5% bupivacaine in increments up to 15 to 20 milliliters. We'll commonly utilize Exparel for these blocks as well, since they are approved for it. And let's talk about a case study for this interscalene. So this patient, actually, sad story, was they damaged their shoulder by dropping their coffee, believe it or not. And when they tried to reach for their coffee, they put their hand out and everything they braced themselves with their hand, but everything kind of reverberated back up to their shoulder. And here we were. That was I said, you just got to let the coffee go. You can come back to Starbucks. We provided this patient interscalene block. We gave them 2 milligrams of Versed throughout the process of providing the block. I did provide this patient zero point 0.1 milligrams of glycopyrrolate and 4 milligrams of Zofran as we were rolling into the OR. There's research that if you provide 4 milligrams of Zofran, you can blunt some of the peripheral serotonin receptor activation. And this patient's surgery was to be conducted in a beach chair position, and I wanted to inhibit the basal gyrus reflex, as it's noted that the basal gyrus reflex can be stimulated and activated by peripheral 5-HT3 or serotonin receptors. The patient was provided a general anesthetic with a general ET tube. They were relaxed due to their positioning. 100 micrograms of fentanyl was provided, 20 micrograms of Precedex, and 8 milligrams of Decadron was also given. They woke up with a numb arm and no pain. Um, their block lasted them 3 days. And one of the fun things that I like to do with the patient sometimes is to, um, I'll ask, how well can you move your shoulder? And then after we block them, I'll sometimes have them say, like, how well can you raise up your arm now? And some of the great things, they're like, I can't raise my arm at all. They've really developed that motor block. And that goes back to that slide discussing how well that local anesthetic has started to bathe some of those inner and very thick nerve fibers. Um, so the next time after listening to this lecture, which I'm very appreciative of those who are, next time you perform a nerve block, begin to examine how that nerve block begins to progress. And as they start to discuss some of the subjective things that they feel, and then once they start to develop that motor response goes away, or if you start to notice that their extremities becoming warm, all of these things refer back to slide 10, and you'll begin to see how the block has really progressed throughout. It's really, really interesting. But the patient had a great result, and next time just drop the coffee. Don't worry about it. This is an ultrasound image of a supraclavicular nerve block. We perform these blocks for our hand surgeon as our goal is to anesthetize the trunks and divisions of the hypoechoic oval structures called the brachial plexus. The patient position for this is semi-sitting, just as I mentioned for the last one, like a semi-Fowler's position, with the head rotated to the opposite side of the operative extremity. The initial landmark by which I will place the transducer is at a transverse orientation approximately at the midpoint of the patient's clavicle. The brachial plexus will be visualized laterally and superficial to the subclavian artery, which is the main landmark for this block. The subclavian artery will appear as an anechoic round structure. The pleura is a hyperechoic linear structure visualized below and on both sides of the artery. The first rib is a hyperechoic linear structure located deep to the subclavian artery. These are key landmarks we want to identify, and we do not want to advance our ultrasound needle anywhere past these structures as the pleura can be penetrated. When performing this block, tilt the transducer caudally toward the chest to obtain a view of the subclavian artery and insert the needle in plane while maintaining a very shallow depth, again, to be very conservative and you don't want to get anywhere near the pleura. When you enter the plexus sheath, you will feel this nice release. Again, that's kind of that art form of learning how things feel tangibly with your ultrasound needle. And then this is where you turn on your nerve stimulator and you'll examine a motor twitch response, which will indicate you're in the correct location. I'll then ask the pre-op nurse, as I always do, to aspirate and provide 5 milliliter increments of 0.5% bupivacaine up to 25 milliliters. Again, it all depends upon the patient's kilograms, whether we give them more or we give them less. But it's important to inject some local anesthetic around the lower trunk of the brachial plexus to ensure a block coverage of the median and ulnar nerve occurs. So once you get the needle to the lower trunk, then I usually withdraw my needle carefully and provide local anesthesia around the middle and upper trunk so they receive full coverage. This is a very satisfactory block as well, just because of really just looking at those bundle of grapes of the brachial plexus is very fun to do. I actually performed one of these blocks today and an interscaling block today, so that's kind of fun. But this block in particular, as well as interscaling and with all blocks, it's very important to visualize your whole entire needle, especially the distal tip of your needle, um, just due to the vital structures that are around there, and really utilizing all the proper body mechanics and ensuring patient positioning. And you really have to be squared away with this block just because you don't want to penetrate the pleura. And as you see in these pictures, you can see the ultrasound needle on the right. The left one is just an initial photo where you can see those two hypercoic lines, as I mentioned. You can see the subclavian and those bundle of grapes, but on the right image, you can see that ultrasound needle, even the distal tip of it, as I'm kind of right in the middle trunks, I would say there. Um, so supraclavicular blocks, they're really fun to perform, um, but you always have to just visualize your needle. That's the biggest takeaway there. So I like to discuss a case study for the supraclavicular block. So this patient was to undergo a left proximal row carpectomy. This patient was provided a supraclavicular block in the pre-op area. Again, I gave him 2 milligrams of Versed for patient comfort. There are times where I don't always provide patients 2 milligrams of Versed. Sometimes I may provide them some Precedex. It all depends upon their age or how they may present to me. Or I may provide more than Precedex, Versed, and I may provide them Precedex in addition to the Versed. As I will discuss in a future slide, there is a multimodal aspect to providing medications such as Precedex or dexmedetomidine and dexamethasone, or aka Decadron, as it relates to prolonging a block, as well as its effects on really just making it more profound block. But this patient was provided 2 milligrams of Versed for patient comfort. I provided the patient 25 milliliters of 0.5% bupivacaine. The patient was taken back to the operating room. They're provided an LMA with general anesthesia, no relaxation. For this case, 8 milligrams of Decadron was provided, 15 micrograms of Precedex, 4 milligrams of Zofran, and 100 micrograms of fentanyl. The patient reported a pain score of 2 on post-op day 2. Procedure was very involved, but again, utilizing this multimodal 8 milligrams of Decadron, you all have probably seen this trend now where there's some Decadron and some Precedex in the picture there, just because of its positive effects on the nerve block and local anesthesia spread. So this is a really fun portion of the presentation here, and we get to talk about how we utilize the Sonocyte ST's features to facilitate a nerve block. We're about to play this video for you all, and it's me scanning one of my colleagues. And one of my favorite features of the Sonocyte ST machine is the Activate Voice feature. The pre-op nurses really get a kick out of it because they know when I really like a block, I save a lot of images. But also it's really cool because you could use the color Doppler, and it really has made things more streamlined. And I think you all will really enjoy this video, but I really wanted to show off how great of a product Sonocyte has produced with this Sonocyte ST machine. So enjoy this video here. Hey everybody, Bradley Quarles here, nurse anesthetist with Salem Anesthesia. Just want to take a moment to talk about some of the features that we enjoy with the Sonocyte ST machine, as it helps facilitate a lot of the things that we do and to provide a patient a great experience when they receive a nerve block. I have my colleague here laying down, and we're going to examine his popliteal artery and his common peroneal and tibial nerves. So we really enjoy this image. We can see the popliteal artery bounding there. So we'll say activate voice, color on. You can see that there. Color off. Okay, so we'll do an initial picture. So we'll say image save. Okay, let's say, as we see him sort of bifurcate here and come together. Okay, sort of form that locus sheath here momentarily. Now, if we like this image, we'll say image save. We can even say brighter, brighter, darker, darker. Okay, and then we'll scan more distal. Clip save. And this will save a video for you to tell the story of how they were bifurcating and they came together of the two nerves to give you that popliteal sciatic block. So as you can see, that these are some of the features that we really enjoy with the Sonocyte ST machine, and it really helps us facilitate as well as tell the story of the nerve blocks that we provide. This is a great thing because it helps us study the nerve blocks after we perform them so that we can get extra mileage and learn, and that way we can better impact our patients in the future. We hope you enjoy the machine as much as we do. Thank you so much. So now we're going to discuss multimodal anesthesia. So as I mentioned in some of the case studies, and you've probably noticed the trends of the utilization of Decadron or dexamethasone and Precedex or dexmedetomidine. So we utilize two medications to enhance our peripheral nerve blocks. Dexmedetomidine, also known as Precedex, prevents the firing of new action potentials. These action potentials are what generate further eliciting of nerve stimulation. So it prevents that new firing. It also has an effect on C fibers and its vasoconstrictive properties via alpha 2 adrenergic receptor activation near blood vessels extends the effect of the local anesthetic. So those are all great key features there. Also helps smoothen out your anesthetic synergistically, meaning that it helps the patient emerge from anesthesia more smooth, due to the fact that Precedex will inhibit norepinephrine release, and norepinephrine is our stimulus for arousal or being awake. It kind of keeps them nice in that bay. It's a very smooth anesthetic with Precedex. Commonly, I'll use 0.25 mics per kilogram for emergence delirium, but it all depends upon really what the patient is presenting to you on the monitor. If it's a very dense early block, then if they're not showing you any sympathetic signs for you to utilize Precedex, then you don't use it. That's why sometimes I will utilize Precedex in the preoperative area when maybe the patient will be a little bit nervous. I'll give them a little Precedex to go ahead and get it on board. Um, but it won't, but once you make that transition to the general anesthetic and everything's more relaxed, sometimes it's harder to work in that Precedex as a result of its alpha 2 properties. The next medication that we utilize is dexamethasone or Decadron. It prolongs the peripheral nerve block duration and reduces pain via its anti-inflammatory properties. We give all of these medications systemically, meaning through the IV. We don't put any of these medications in our actual syringes. Um, there's been data that's come out that says it's equally efficacious if you just utilize it systemically. So that's what we utilize. For Decadron, we'll use 4, 8 milligrams, but we really tend towards giving 8 milligrams. A lot of our patients preoperatively will get 100, they'll get a gram of Tylenol and 300 milligrams of gabapentin. So there's a lot of multimodal anesthesia occurring at our facility, and I work at an ambulatory surgery center. So of course, the whole key there is just to have smooth emergencies, enhance recoveries after surgery, limit nausea, limit fluid retention or urinary retention. So all of these things really just help facilitate the flow of the patient. And I think the one thing that I was learning as a new anesthetist is that it's a different mindset when you work in these ambulatory outpatient surgery centers because your focus a lot is on the recovery and the PACU. Um, but as one anesthetist told me once, your wake up begins in pre-op. And that's never left me. But these are some of the great medications that we utilize to help facilitate the multimodal anesthesia, but also the great outcomes we enjoy with the regional anesthesia. So now let's talk about the future of regional anesthesia. I think regional anesthesia is really going to begin to have more of a role in the overall care being provided in America. I think as our patient populations become sicker, and when it's not contraindicated and the comorbidities allow for regional anesthesia to be administered, I think it will be beneficial to administer it and to facilitate, to allow the patient to have this nerve block because you're blocking the pain right at the source of generation. If the patient's hypertensive, providing regional anesthesia prevents them from being in pain, more hypertensive. If they're have cardiovascular supply demand issues, you limit the sympathetic nervous system response and release, so they won't have such a higher heart rate, not putting a demand on the heart. So they have better oxygen delivery. As it relates to pulmonary patients, who have lung issues, allowing them to take a deep breath to prevent atelectasis is essential. So all the major vital organs and really just preventing the overall cascade of histamine cytokine release that occurs from pain is it's a second to none. I think regional anesthesia is only going to have more of a profound role to play in overall care of the patient. But I do believe newer drug additives will become on the market to prolong the block duration. I discussed a few of them: Exparel, Decadron, dexmedetomidine, such as Precedex, in this presentation. But of course, like everything else, there will be new things that will come out. I think that's going to help out with performing nerve blocks. I think new nerve block techniques which will better target our surgical sites, will come on um, to the foray of options that you can provide to a patient. And more widespread knowledge of ultrasound machine among all medical professionals. And I think that's really essential. I think more knowledge, and this is why I'm so thankful for this webinar and to have this opportunity, is just because I get to play a role in that, in helping spread some knowledge about the ultrasound machine and how regional anesthesia can benefit patients in various populations. So I thank Sonosite for that. And I think also there will be increased acceptance of regional anesthesia and its benefit to the patient. Sometimes regional anesthesia can have it can appear as though that we're slowing things down, or you have to fit it into the schedule. Um, but it's essential for patient outcomes and care in their recovery after surgery. And it's all about the patient. It's all about the patient. It's all about the patient laying in the bed and um, the ability to eliminate all these negative effects of them taking narcotics postoperatively. I'm not saying that regional anesthesia is the magic wand that no patient will ever take a narcotic again postoperatively. Some patients may have to take a narcotic, and that's okay, but it vastly reduces it. They have a better patient experience with regional anesthesia. Um, it's my hope that you all enjoyed this as much as I enjoyed crafting it. And let's just keep advocating for the patient, keep seeking great patient outcomes. And I thank everybody and I thank Sonosite for this opportunity. So thank you all very much.
All right. Thank you so much, Bradley. I think it's time for our Q&A section. It looks like we've had quite a few questions come in so far. And Bradley, you've been doing a great job of answering those throughout the presentation. So thanks for that. Is there anything else that you want to kind of talk about with regards to your blocks that you do?
No, can you hear me okay?
Yeah, he sounds great.
No, thank you all for tuning in today. This is a huge honor, and thank you again to Sonosite and Salem Anesthesia and all the people who've helped me get here today. No, I don't have anything really more to add other than I really enjoyed doing it. You see the benefits of providing it. I know a story I can tell about last week was that this lady came in. She essentially, what she told me, now her arm was all bandaged up, was that she got in a car crash and her thumb was, I mean, poking out of the bone of her thumb was poking out. Uh, Performed a supraclavicular block for her, and it literally had the effect on her as if placing an epidural in a laboring woman. You could just see her just kind of melt in her eyes. You could see the patient becoming more comfortable. Um, and I think that's what I enjoy about it. You can just there's a lot of subjective signs that the patient demonstrates, but also the objective. And ultimately, there's nothing better than having a pretty involved procedure and the patient waking up feeling comfortable. And to provide that is it's really cool and it's really interesting to do. And that's what I really enjoy most about regional anesthesia. And it's just always a challenge. It can always be a challenge, and nobody's ever the same. I think one of the people within the Q&A um, was asking, do you usually do the femoral condyles or do the shaft? And it all really depends as to what the patient's anatomy is and how they present. I can't say that I empirically do all of one thing or give everybody all the same haircut. It all depends upon when I place that transducer upon the patient, what is presented, and we tackle it from there. And it's really just a dance between you, the patient, and utilizing that transducer as your paintbrush and try to perform it as best as possible.
Well, that's awesome, Brad. Thanks so much for joining us. It doesn't look like we have any more questions coming in, so it looks like we're a little bit past the hour here. But um, thanks so much for joining us today, Bradley. Really appreciate it. Everybody else, like we said, we're going to have this recorded and up on the sonosite.com/behind the scan webinars page, and you can go ahead and scan that QR code there to go right there. And it'll also be up on the Sonosite Institute as well. So once again, thank you so much, Bradley, for taking the time to put together this presentation and hanging around to answer questions and stuff for us. We really appreciate you, sir, and your expertise.
Well, thank you so much, and I appreciate all the great team at Sonosite, and thank you for the great products that help us deliver great results for our patients. We appreciate it.
Awesome. Thanks so much. We'll see you guys at the next